Uh, Start the presentation.
And whom am I addressing?
Ma'am,
Whom am I addressing?
uh, directly your start the presentation.
I understand, but whom am I talking to?
Uh, Directly presentation directly, not.
I agree, but whom am I talking to? Who is my audience? Who is watching this?
హలో
Yes.
మేడం మీరు అది డైరెక్ట్లో మాట్లాడుకోవచ్చు. అది
Evertoti, whom am I talking to?
ఆడియన్స్ మిడిల్లో కామెంట్స్.
Hello.
హలో
Hi, Aparna. I just wanted to check with you that we are just going to start this. So who Okay, I hope somebody is listening to this because I don't know who is the audience here. And I have been asked to talk on the fetal perspectives of torch infections. So, the torch infections are a group of infections that have this particular nice mnemonic called torch because you include toxoplasma, other infections like syphilis, varicella, hepatitis B and Zika virus, etc., rubella, CMV, and herpes. All of this come under a umbrella term of torch, and they are basically important because they can affect the fetus through transplacental transfer of the organism. So when we do the torch test, which again is a source of a lot of confusion amongst obstetricians and pediatricians, so we thought we will address this topic because the torch test that is always done is a serology test and it tests for the maternal antibodies. Antibodies are products that are produced in the body after an infection is present in the body, and I am getting a call from someone, but I can't take it now. Yeah. So it tells us whether the woman herself has reacted to any of the torch infections or has had previous vaccination. We have two types of antibodies that are tested in the torch infection. One is the IgM that tells you about the recent antibodies, and one is the IgG, which tells you about old antibodies or the immunity. So the interpretation of the maternal serology is very important. So when you have the torch report in front of you, if you have an IgM negative and an IgG negative, it means neither recent infection nor past infection. It also means there is no immunity available. And if there is a vaccine, it's a good idea to give the vaccine. If it is IgM positive and IgG negative, then it could be either a false positive or it could be a recent infection for the first time. You expect severe sequelae if it is in the fetal period, where suddenly an IgM is positive and IgG is negative, and you try treating the primary infection. If the IgM is positive and IgG positive, then it may be that the IgM has persisted for some time, but the IgG has now taken over. So that could be a recent infection with some immunity which has started to develop. Sometimes it may be an indication of reinfection, and therefore you need to do something called an avidity test. The IgG avidity tells us how long back this infection was there. So if it is a low avidity, you will have a recent infection. If it is a high avidity, you would expect an old infection more than 3 to 6 months old. So avidity helps in timing the infection. And if you have IgM negative and IgG positive, that is one of the best combinations to have, because that says that there is no recent infection, but there is immunity based on past infection or vaccination. So no treatment is needed and no vaccination is needed for a condition where IgM is negative and IgG is positive. That indicates maternal immunity to that particular condition. So do we do torch test today? Yes, we do torch test today. When do we do torch test? It's always a fetal perspective. So whenever you have a ultrasound sign of some kind of fetal infection, then you do a maternal torch test. Do you do otherwise when you don't see fetal problems? Yes. If there is a pregnant woman who complains with fever, with rash, sometimes even without rash, it's a good idea to rule out the torch infection in any febrile condition of the mother, because many of these infections might not be startly symptomatic. So if it is pre-pregnancy, you can do a torch profile to look at the immune status of the mother, but mostly it is useful if you have a vaccine. And you have a vaccine for rubella. So at least checking the rubella IgG prior to pregnancy makes sense. If the IgG is positive, then that's good. You don't need to do anything. If the IgG is negative, then it is good to give a vaccine for rubella. In recurrent pregnancy loss, there is no role of torch test. And that is why actually it went into disrepute, because initially people started doing torch test for recurrent pregnancy loss. And as you can understand, once an infection has happened, there will be immunity for the future. So you don't always have repetitive problems with fetal infections. And therefore, in repetitive problems like recurrent pregnancy loss, there is no role of torch profile. So in obstetrics, the role of torch profile has now shifted to a fetal perspective, where you're worried more about the fetus getting affected by the torch infections. So one of the myths we have in our society is that we don't have these infections and hence we don't need to test for these infections. So I will show you one case where this woman has come to us at about 33 weeks of pregnancy, where it's a second gravida, previous cesarean section, no significant medical or surgical history, but there is some unusual finding on the ultrasound scan. So she was referred to us because, as you can see here, there is fetal ascites. There is fluid in the fetal abdomen, which is also known as fetal ascites. And the woman gave a history of some fever. But with the current picture, with fetal ascites and polyhydramnios, with a large for dates baby, because when you have ascites, you will have a large abdominal circumference. And when you have a large abdominal circumference, you will have a large for dates baby. So with fetal ascites, with polyhydramnios, with a large for dates baby, we also noticed a slightly prominent cavum septum pellucidum, and the different combinations were leading to different pathways. Congenital heart failure, congestive heart failure, anemia, gestational diabetes, neurogenetic syndrome. So everything was falling into a kind of diagnostic puzzle. But when you start ruling out things one after the other, so if you think of anemia, you do the MCA peak systolic velocity. MCA peak systolic velocity is normal, so you don't have anemia. Then you do the maternal serum ICT that is negative, so you don't have any immunological condition in the mother. The maternal torch profile was done because there was a history of fever in the past, and polyhydramnios as well as ascites are markers of fetal infection. So here we found both toxoplasma IgG and IgM were positive. Now that was ruling in toxoplasma infection, but considering that she was 33 weeks, we did the avidity, and the avidity said low avidity, which meant the infection had happened within 3 months. A maternal toxoplasma PCR was done, which is not always essential, but that also said that the woman herself was carrying the toxoplasma antibody, toxoplasma nucleic acid, and therefore she had an element of infection. So now we have a condition of IgM positive, IgG positive with low avidity. That means there is a recent infection. So the timing of the infection is very important, because if the infection is within the pregnancy, then you expect some effects on the fetus. If it is a past infection predating the pregnancy, then you do not expect any impact on the fetus, because the transfer of these infections is transplacental. So since the avidity was low, we assumed that this is a recent infection, and we counseled the couple and did what is called an amniocentesis. So from the amniotic fluid, we assessed the PCR for the toxoplasma nucleic acid, and we found that the toxoplasma RNA was positive in the amniotic fluid, which means there were elements of toxoplasma in the amniotic fluid. How will it come to the amniotic fluid? The mother having the infection has a transplacental transfer, which goes through the placenta intravascularly into the fetus. And since the fetus excretes these organisms in its urine, it comes into the amniotic fluid, which is predominantly formed by the fetal urine. So now this fetus has been infected. It is affected because there is ascites, but there can be more implications of the toxoplasma. So we think of a treatment. Luckily, toxoplasma is one of those infections which has a treatment. So the treatment that is available for toxoplasma is antenatal administration of pyrimethamine and sulfadiazine to the mother. So this woman was given this a treatment, and then she was followed up. And at 36 weeks, 4 days, she delivered a baby girl who was absolutely fine. And the baby was also started on pyrimethamine and sulfadiazine drops postnatally. Luckily, the baby did not develop any serious neurological complications, and the retinal and ear examinations postnatally were fine. Because the treatment was started, so although the fetus was infected and affected in utero, it did not have long-term postnatal sequelae. So when it comes to toxoplasma infection, the mode of transmission of most of the infections is kind of similar, where you have a less transmission early in pregnancy because the placenta itself is very small, more transmission later on in pregnancy because you have huge connections between the fetus and the mother. However, when it comes to the ability to affect the baby or to cause, a fetal neonatal infection or the effects on the fetus, then the ability is much higher if it is in the early pregnancy, because first trimester problems generally cause severe fetal sequelae. So this problem had happened in the third trimester. So the ability of the infection to pass to the fetus was high, and that is what happened. The fetus got affected. However, the impact on the fetus was not that high, and with treatment in time, the outcome was good. So whenever you suspect a fetal infection, the gold standard of diagnosis is isolating the infective nucleic acid in the amniotic fluid, which tells that the fetus has the parasite has now passed through the fetal circulation and excreted in the urine. If this fluid test is negative, it doesn't mean there is no infection. And if it is positive, it doesn't mean the fetus will definitely have sequelae. It only means that the fetus has got infected. So in toxoplasma, you have this classical triad where you can expect chorioretinitis, intracranial calcifications, and hydrocephalus. However, because things were managed in time, in this particular case, you did not have any sequelae. So the treatment for toxoplasmosis in pregnancy is pyrimethamine and sulfadiazine, but there is another drug which is very well known in terms of fetal infections, and that is spiramycin. And the role of spiramycin in toxoplasmosis is preventing mother to child transmission. So when you suspect that there might be an infection in the mother which might go to the fetus, you can give spiramycin as 1 gram 3 times a day to prevent mother to child transmission. The sulfadiazine pyrimethamine is given to treat the infection. So one has a preventive role, one has a therapeutic role. So again, you have this maternal serology, which I cannot overemphasize, and one needs to understand this because it is very sad. We have seen patients being terminated because of the wrong interpretation of these serology reports, and it is important that we understand this correctly. I've already explained this in the past. I'm flashing it again just for you to understand that. So IgM is recent infection, IgG is old infection, and how old the avidity test will tell you. So this is how the torch report looks, and many doctors just get intimidated looking at that report, seeing so many entries there, some of them highlighted, some of them not highlighted. Yesterday also I got a call from somebody that the IgM is very high, madam, should we do something? Maybe it is something, but it's simple thought process. Once the IgM is negative and the IgG is positive, that means whatever initial activity had to be done has already been done. And now if the IgG increases, it really doesn't mean anything unless you have a recurrence where you have a serial increase of the IgG and also a concurrent IgM increase that way. But a recurrent infection always has a milder phenotype because you really don't have that severity in secondary infections. And these avidity results, if they are less than 30 to 35%, then you think that it might be a recent infection. But if it is past 40%, as high as 70 and 80%, as you can see in these results here, then you can relax because this is an old infection. So low avidity is recent infection and high avidity is old infection. Final confirmation always by the amniotic fluid PCR. And this is something we do. We do in cases where we suspect infections in the fetus. And primarily, there are some ultrasound markers which give us a sort of hint that there might be a torch infection. And it's a good idea to do it there because then only you will know whether or not it was an intrauterine acquired infection. So the pathogenesis of these infections is whenever the particular virus or parasite reaches the fetal tissues, there will be replication of the parasite there, and that leads to inflammation, tissue necrosis, and finally organ dysfunction. If multiple organs are involved, you may also have fetal demise in utero. So there could be growth restriction, there could be fetal demise, there could be polyhydramnios, there could be oligohydramnios. So everything is possible with fetal infection. The primary concept which we all need to remember is that the transmission is transplacental, and therefore in the early pregnancy the chances of transmission are less, but if it gets transmitted because the fetus is at a very, very early developmental stage, the effect on the fetus will be very severe. Whereas if the transmission is in the second or third trimester, the sequelae are less intimidating than what happens in the first trimester. Some of the infections like varicella can affect your decision of the mode of delivery, timing of delivery, because you wait for the maternal antibodies to develop and protect the fetus as it passes through the genital tract. So always suspect torch when the mother has fever with rash and not if otherwise. That is a myth. Some of the infections can be completely asymptomatic. So whenever in doubt, you must test the mother for the torch serology and if necessary, test the fetus. So when will you be in doubt? So these are the ultrasound features in the fetus which tell us that maybe they can be a marker for everything else. If you have ventriculomegaly, it may be a genetic condition, it may be a structural malformation of the central nervous system, but it can also be because of a intrauterine infection like the torch organisms. Calcifications, cerebellar cysts, Vermean hypoplasia, cortical development malformations, because when you have a malformation of cortical development. It might be because it's not forming because of a genetic impediment to the maturity of the CNS. It can also be a clastic activity where something is already formed and then it has started getting destroyed. For example, there was a good corpus callosum seen at say 19 or 20 weeks. But when you see at 26 weeks, something has happened and now the corpus callosum does not look good and most of the parts of the brain look abnormal. That can happen if there has been a severe infection somewhere in the intervening period. And therefore, in all these findings, where you have very, very growth restricted babies, hyperechogenic bowel, hepatosplenomegaly, calcifications, skin edema, high drops, placentomegaly, calcifications, oligo or polyhydramnios, while there may be so many other things in the differentials, but torch infections need to be ruled out. And the simplest way of ruling out torch infections is to do a maternal torch profile first. Because if the mother shows clear-cut evidence of old infection and immunity, then you need not be worried about the fetal infection. So these are some pictures which I have taken from the guideline on the ultrasound features from the International Society of Ultrasound in Obstetrics and Gynecology, because it has been really nicely collated. And I don't need to rediscover the wheel, because when we see different cases, we see individual findings. But here they have put together all the possible findings. And whenever a person who does ultrasound sees a megacystoma magna, slightly distorted corpus callosum, sometimes atypical clastic lesions in the brain, which doesn't really form into one particular pattern, but it looks like something is destroyed there, something is disturbed there, because this is kind of a destruction of well-formed central nervous system features. Then you should think of infection. In the placenta, calcifications, less liker, more liker. So, I've been repeating the same things over and over again, because the importance of people to realize that whenever we have one of these conditions, please look for that infection, because it gives a closure to a lot of things. So many of us think we don't have this problem in India. So in fetal medicine and obstetrics, I think we are still struggling to tell people that yes, we have this problem in India. I think my neonatology colleagues or the pediatric colleagues will not disagree with me, because they do see sequelae of these problems, but they see it later. And because we all tend to work in silos and we don't talk to each other and we don't report such problems to each other, it becomes a nightmare of misinterpretation. Because if there is a child who has sensory neural hearing loss or a microcephaly because of a primary CMV infection that the child acquired in the intrauterine period or postnatally, the entire workup of this child has to be done properly, so that in the next pregnancy, the mother can be reassured that this was because of infection and now this is not going to happen again. What happens is, whenever there is a child with neurodevelopmental delay, everybody starts going overboard and doing a number of tests. But suppose you have determined clearly and unequivocally that the problem in the first child is because of a CMV infection, then where is the problem? See, the mother can be tested for the CMV immunity, and if she's immune to CMV, she is not going to have another CMV infection with the same severity, and they can actually be reassured. So in most of the genetic conditions, we want the baby to be worked up, because you will do a lot of workup in the next pregnancy. But in infections, you need to do the workup so that you don't do unnecessary workup in the next pregnancy, because the next pregnancy is going to be completely uneventful, and it's good information to give the patients that you are immune for this condition and you will not have this problem later, because they seem to be extremely distraught with the entire picture. So in CMV infection, we can actually confirm it by amniocentesis, and we need to do serial ultrasound examinations and an MRI at 28 to 32 weeks. Now, in India also, the termination of pregnancy law has changed. And if there are late onset problems, which we could not predict adequately in the antenatal period early, then suppose it is a severe morbid situation or a severely debilitating situation, we can approach the medical boards in various states to, get an option of even a late termination of pregnancy. And especially in the realm of infections, it is a very useful thing that today, if you have a very symptomatic fetus in the third trimester, you have some some option of not continuing with the pregnancy at that point in time. However, if there is in utero treatment available, then the situation changes, because if you can start the treatment on time, then the effect on the fetus is going to be very minimal and the outcome is going to be good. So in terms of CMV, the drug which has been tested and tried for in utero treatment is valacyclovir, and this can be given until delivery. Post delivery, one has to do auditory and ophthalmic examinations and the neurodevelopmental examination of the baby, because they can have sensory neural hearing deafness and long-term neurological developmental delay, which of course a pediatric neurologist has to follow up. In fact, CMV is the leading cause of non-genetic sensory neural hearing loss in children. So for us to write off notch infections that we don't have them is not correct. And whenever it is doubtful, we should know. There is some of the experimental things going on about preventing the CMV transmission by hyperimmune globulin, but still experimental, not yet like completely ratified for clinical use. Rubella is a somewhat dangerous infection where the mother to child transmission, even in the first trimester, is like 90%. And the effects of rubella are extremely severe. So at all levels, at all organs, the effects of rubella can be very, very debilitating. And this is the one infection where the outcome is so poor that even in textbooks and guidelines, the clinician is justified in offering a termination of pregnancy if there is a proven rubella infection in the first trimester. So we need to diagnose it in time and we need to act on it particularly well. So the only good thing about infection again is that the risk of recurrence is extremely low. So even if a woman loses one pregnancy because there is a rubella infection in the first trimester, she can be reassured that in future this is not going to happen. I will share one interesting case with you where a 35-year-old primigravida comes to us at 12 weeks. She's a known case of type 2 diabetes on insulin, and somewhere somebody had noted an increased NT, but at that time the CRL was about 43, so we did not consider that as appropriate and repeated the NT scan. The repeat NT scan surprisingly turned out to be normal. However, because it was already increased at some point and the woman was 35 years, she wanted clarification, so we planned for doing an amniocentesis at 16 weeks. As a routine protocol, we do a torch profile whenever there is increased NT, because infections of the fetus is another pathogenic mechanism for the increased NT. So her report came like this, and her IgM was borderline high. The only thing is her IgG was also high. So I was not particularly worried, but then this was a very, thinking kind of patient, and she was absolutely worried with that IgM. And then we repeated the titers and it didn't seem to change a lot. So we thought it was a false positive IgM. But again, you know how it is. Anyway, we had planned an amnio at 16 weeks. So with the amnio, we decided to do a torch PCR also. But before we did the amniocentesis, I did an ultrasound scan. And in the ultrasound scan, surprisingly, we found that stomach was in the abdomen, no doubt. But in the process of the scan, I saw the stomach sliding up into the thorax, and this was a case of a sliding diaphragmatic hernia. So the contents of the when we started the scan, there was not that much of a mediastinal shift, but in the process of the scan, we saw that the intestinal contents were going into the thorax and then coming back from there. So there was a defect in the diaphragm, and that was allowing a sliding of these contents. And so that explained why the NT was increased at the 43 CRL and then not increased later on, because whenever there is pressure in the mediastinum, you will have that fallout of the increased NT, but otherwise it may not have been there. So they opted for an amniocentesis any which way because of that history. And in addition to the aneuploidy, we also tested for the rubella RNA PCR, and it was clear that it is not there. So there was a rubella IgM positive. There was an increased NT. There was everything else. But when you put all the things together, you realize that everything is for a different reason and you need not allocate one to other and get confused. So the woman did not have a rubella infection and she had a sliding hernia. She went on. She was delivered at 31 weeks due to PPROM and underwent an exit procedure and had a diaphragmatic hernia surgery done on day 5. The baby was alive and healthy. So the torch report could have caused a lot of havoc because the way it was being interpreted at that time and the way the pressure was on us to react to that IgM positive is sometimes very intimidating. People sometimes don't go to the long route and they just see an increased NT and IgM positive rubella and terminate the pregnancy right there. So these tests are always ELISA based tests. So you have to understand the serology and not just get excited with one serological abnormality. The important thing about rubella to remember for all of us is it is a preventable disease and there is a very good vaccine and it costs less than 100 rupees. And any woman who is in the reproductive age should have at least been vaccinated for rubella. So if a woman is vaccinated, she is advised to avoid pregnancy for about 1 month post-vaccination. And if she is pregnant by mistake in that 1 month, that doesn't matter. She can continue her pregnancy. Postpartum vaccinations can be done. Breastfeeding is not a contraindication. So wherever possible, we should advocate the rubella vaccine. The myth was that you have to avoid pregnancy for 3 months, or if you get pregnant, you need to terminate the pregnancy, but that is not true, and it is not a very expensive vaccination. So TORCH is an ELISA test, and we can have false positives and false negatives, and therefore understanding the serology is very important because we can take very, very unjustified clinical decisions if we do not understand the serology correctly. The other infection that we encounter commonly in the fetal-maternal clinics is the herpes simplex virus. And again, the neonatologist will agree that herpes is again a cause of their CNS infections, and therefore it is important for us to know how to handle it in the antenatal period. So the primary HSV infection is one where the woman had never had this infection in the past and has developed this for the first time. Whereas you can also have secondary infection in women who've had some kind of immunity in the past, or they were infected with one variety and now they have the cross infection with another variety. So we need to give them antiviral medication in addition to partner screening, barrier contraception, and the entire treatment. So this is the recommended treatment for herpes simplex in pregnancy if it is a primary dose. If it is a primary episode, then you give an episodic treatment for 10 days, and 36 weeks onwards, you give acyclovir or valacyclovir as a suppressive treatment. If it is a recurrent episode, then you give an episodic treatment only for 5 days and the suppressive treatment remains the same. So you have acyclovir or valacyclovir as options. The doses also are very much similar, but the duration of treatment for primary is about 10 days initially and then suppressive treatment from 36 weeks. For secondary is 5 days initially and suppressive treatment after 36 weeks. So one of the myths is once you are infected, lifelong risks remain. And this is very important for all of us to understand because I have seen patients being told to avoid pregnancy till the IgG becomes negative. And that is an extremely sad situation because I have seen women hold on for 3 years because the rubella and repeating the torch profile endlessly. The IgG is still positive, still positive, still positive. It is actually really sad. We should not be doing that. And we need to understand what are the types of infection that the mother has, primary or secondary. And whenever IgG is positive, G is for good. So, it's good. It's something which will prevent the severity of the infection and even prevent reinfection. And that we need to be understanding it. So I cannot overemphasize the interpretation of this TORCH report because I don't know how it is in the pediatric sector because I haven't interacted with them on this count, but I have seen people with CMV infected babies who have been told to avoid pregnancy in future and that they can have a similar baby in the future, but that's not true. If they have neurodevelopmental delay because of CMV induced microcephaly and other problems in the first pregnancy, they are better off in the next pregnancy. They are more likely to have a normal child. And I don't disagree if somebody wants to do a genetic testing to rule out other conditions. But when something is just staring us in the face and that infection is the pathology, then we need not become all hyped up and do unnecessary genetic tests. So please don't treat rubella IgG positive cases. The drug which is commonly advised to everyone is called rovomycin. And we see rovomycin being advised right, left, and center, even to non-pregnant women, even for rubella, IgG, and I think it's completely unnecessary. The only role for ovomycin, which is actually spiramycin, is in preventing mother-to-child transmission in a case of toxoplasma, not other infections, only in a case of toxoplasma. So please don't keep treating IgG positive cases. So anybody with seropositivity in TORCH profile is given rovomycin. That is completely wrong, and that should not be done. So the points which have no controversy is any woman who has fever with rash in pregnancy, or there are ultrasound signs suggestive of an infection, do a TORCH profile. It is better to do a TORCH profile than not do it, as long as you interpret it correctly. IgM is recent infection, IgG is old infection. Understand this fact. IgG avidity helps in timing the infection. Prenatal diagnosis can be confirmed by amniotic fluid PCR whenever required. If you prove an infection, there is an individualized prognostic workup and you can plan treatment as and when possible. Different drugs are available for different organisms, and now there is a standard way of dealing with it. Suppose it's a very, very bad situation and you think of discontinuing this pregnancy, then it will not happen in future. The recurrence of these problems is very, very minimal, and it definitely not in the same severity. Whenever you can prevent something, prevent it by doing timely vaccinations. So in terms of fetal infections, suspect the infection, diagnose them timely, and treat and manage them appropriately, because we need to understand the concepts so that we don't do any harm to our patients. Fetal infections or this entire TORCH profile thing, at least in the fetal and the obstetric point of view, I feel there is a lot to be learned. There is a lot of misunderstanding and suboptimal interpretation of this report. I don't know how it is in the neonatal and pediatric group. We have a neonatologist here on board with us. I think I got a message. Uh, mm, Dr.
Hi, ma'am.
Dr.
Dr.
Deepa.
Deepa.
Yeah. So if there's anything that you would want to discuss on this point, it will be good for us to just go through a few aspects.
From neonatologist point of view, what you have told, most of it we agree with that, ma'am. But in pediatrics, when it comes to around 6 to 8 month baby, and we get a baby with some anomalies, that time it becomes difficult to diagnose the infection. Or then we have PCR quantitative, qualitative tests. We need to do that, and information about that is not very clear. So that one difficulty we face.
So basically, at any point, a neonate or a pediatric patient can acquire these infections from other sources also.
Yes, ma'am.
And the only problem what we have from the feto-maternal continuum into the neonatology is we should not have missed if it was an intrauterine infection.
Yes, ma'am. Yes, ma'am.
So for that reason, as soon as the child is born, if you have a doubt, what is the test that you would do to effectively rule out that there is no intrauterine component of that infection, intrauterine acquisition of this infection?
I guess placental.
Yeah,
Sending
but
placenta.
that's like an ideal situation, isn't it? So you will not have an ideal situation. It'll always happen when you take the patient into the NICU and there is some neurological finding in the
Yes.
NICU after a few days of the delivery and you're suspecting.
Yes, ma'am.
So what about neonatal serology?
We do PCR qualitative test.
But the PCR will only be there if the organism is still there.
Yes, ma'am.
So suppose this woman was infected at 16 weeks, had all the sequelae by 18, 19 weeks, and then now you're seeing it postnatally. Do you still expect the
And
PCR?
torch profile would be.
So the serology would be a better thing. And
Yes.
in the fetus, if there is IgG and that is old antibody, but what about maternal transfer of IgG? That is also a possibility.
Yes, ma'am.
So there are a lot of things that you have to see in detail to find out how the fetus neonate got the infection. But in the antenatal period, these are our trigger points. In the postnatal period, the neonatologist has to tell us that, what are their trigger points. So do you agree with whatever I have presented in terms of our approach towards doing the TORCH profile in pregnancy?
Yes, ma'am. Definitely, ma'am.
And would you want all these babies to be terminated or treated and handed over to you?
No, we would want a treated baby.
No. For example, if it is CMV or if it is something and they come to you for an advice in the antenatal period, like now it's a proven CMV infection and we
Yes.
can give treatment, but we don't know what will be the long-term sequelae. If they come for an opinion, so is termination of pregnancy still a reasonable option?
If the anomaly that we see, if it is not compatible with life, yes. Yeah, if not, we could go with treatment.
Yeah, because we cannot always reassure them, no? Like suppose it is a proven CMV infection and we are seeing it at 25 or 30 weeks and we don't know beyond this how severe it will be. And if the parents say that, look, you've told us this won't happen again, so this one time we don't want to go ahead, is there any justification in that?
No, ma'am.
Okay. So I don't think there's any method of getting questions from anyone or anything. I don't know whom I'm talking to actually. So let's kind of,
Thank you,
if there
ma'am. This
is
is
any.
Aparna. Thank you for your very
Hi.
enlightening and extensive session. I
Yeah.
think all those who attended and who will be attending will benefit hugely from it.
So any questions from anyone, or if you want to ask something or comment on something, then might be go.
Ma'am, maybe you kind of touched upon it somewhere, but if you have a very early diagnosis in, say, particularly in CMV, at what point would kind of you consider termination? Would it be based on ultrasound findings or considering the
Yeah, so suppose we have definite calcifications, ventriculomegaly or microcephaly, where there's an obvious CNS alteration, which says that this is going to have neurodevelopmental delay. Then it's easier for us to tell them that the prognosis is really poor and you could consider termination. And like I said, the medical termination of pregnancy law has now changed. So even beyond 24 weeks, we can, sort of apply for a termination permission. And these will be the things which will help us justify our application. However, if it is like we proved CMV infection, we gave valacyclovir and things were good and there is no ventriculomegaly, there is nothing, you still have a risk of sensory neural hearing deafness later on. And when you counsel that, there will be a certain number of people who, at least till now, I have not had patients who have continued after proven CMV infections. With proven toxoplasma, we had a couple, but with proven CMV infections, they don't continue. Herpes is easy to counsel because the effect on the fetus is still very less, and it's more about preventing perinatal transmission. So from our point of view, it's okay. But when we send to the pediatrician, they always give us a poor scenario for CMV and rubella.
Thank you, ma'am. Thank you.
So if that's all, can we call it a day? Any
Yes, ma'am. I
questions?
think we can, ma'am. Thank you, ma'am.
Yeah. Okay. Thank you so much. Thank you for the opportunity of being here. And if there are any questions, you can post on the link and we can answer that later. Thank you, Dr. Aparna. Thank you, everyone.